All right, so I'm Shelley Paule, and I have been the lead implementer of the CANS in San Diego County Child Welfare Services. We were mandated to start using the Child Adolescent Needs and Strengths in October of 2018. And our state was very clear with us that those conversations would happen in the child and family team meeting. So we would literally be completing the CANS with the family in the meeting. So I got to do all of the training. We trained 1,500 staff and created the rollout and the process, and that's been great. And I'm a certified CANS trainer. So for Nevada, if you guys ever need help, happy to come out there. You know, I'm going to stop sharing just because my PowerPoint now is unhappy with me. So let me start from scratch. Here we go. And I just wanted to share a couple overarching concepts. So our counties, there's 37 I lie to you. There's 57 counties in California. We're contracted by the state of California to provide the services for probation, behavioral health, and child welfare services. So the state really created this model for us called the Integrated Core Practice Model that talked about how do we work together. You know, we're not siloed agencies, really. We're all serving the same families for the most part in child welfare services. Since we started using the Child Adolescent Needs and Strengths, we actually refer about 75% of our kids for therapy. So those kids are being touched by behavioral health services. Parents receive mental health services. We have family members who are active to probation. We have kids who are active to probation, and we share cases with them. So really the state's just saying, hey, you guys, we got to all work together, and we have to work together collaboratively in order to do the best job for families. So this is really the foundation. To continue with that, really to ensure the best outcome for children and families who interact with our systems in California, they created continuum of care reform. And the intent of continuum of care reform was to make sure that children and youth who have to be apart from their biological family, that they live in a really excellent environment, no matter what that environment is. So if I live with a relative, if I live with a foster parent, if I live with a family friend, if I live in a foster family agency, or if I live in a short-term residential treatment facility, I should get the same experience and have the same benefits and services no matter where I live. As part of continuum of care reform, they also mandated that all counties start using child and family team meetings. So most of us had been using different types of family-centered meetings, team decision-making meetings, which is a Casey model. We had used family group conferencing meetings, different techniques. And because we were all using different techniques, it was hard for the state to say that families were receiving the same services and benefits in all the different counties. So in 2017, the state mandated that all counties use the same model, which is the child and family team model. It's a great model. Really, it's 3 questions. What's working well? What are we worried about? And what are we going to do about that? So what are the action steps for everybody? We know that authentic engagement with families is the best predictor of treatment success, regardless of our service sector. So in order to really build our relationship with families, which our agency has disproportionately represented families of color, children of color since the beginning of our agency's existence. That's also true in our legal justice system. So we really are working hard to build relationships and to show families that we've changed, right? But in order to do that, we really have to provide them excellent service and make sure that their voice is as loud as ours. So this is one of our key goals of our child and family team meeting. You know, I like to say that the moment we remove a child, our voice gets really loud, like we're screaming out of a megaphone, right? And in order to make our voices the same volume, we come together in the child and family team meeting. So this is why the state put the CANS conversation in the child and family team meeting. Parents frequently didn't understand, no matter how clear we thought we were with them or how collaboratively we created our case plans, our families didn't understand their case plan goals or why they had to do those services. So one of the great outcomes we've had since we started doing the CANS conversation in a child and family team meeting is that their case plans make sense to them. So Liz mentioned if they score a 2 or a 3, they get a service for their case plan attached to that. And it makes sense to parents. They're like, oh, okay, I have a 2 for substance abuse. I need to get it down to a 1 or a 0 in order to reunify with my child. Great. I'm going to go to substance abuse treatment. So when we first rolled this out, it was kind of rough for our staff, right? It was a big, big change, a huge change in how we did business when we converted our mental health screening and this engagement case planning tool to the CANS. But really what I explained to social workers was, we know how to do our job. We understand child welfare, but really a new family coming into contact with us, our system is so massive and it's so complicated. We have to slow down in the beginning so that we can speed up in the end, right? By slowing down and really ensuring that the family, that their voice is heard, that they're part of our case plan process, that they're helping us to rate the CANs. That's how we know we're making good assessments. So our child and family teams are state mandated, I mentioned to you. We have to include the child and youth. By the way, there's no minimum age. I call kids under 3 an adorable distraction at a child and family team meeting. And they're usually distracting the people that most need to be paying attention, right? So in San Diego, we try not to have little kids in this child and family team meeting. Once they're verbal, some kids that's 2, 2.5, 3, 4. We have them come in for about 5 minutes. We ask them what they like. They tell us about food they like, spaghetti, going to the park. We ask them what they don't like. Sometimes they'll tell us about food they don't like, or, maybe they don't like driving someplace. And sometimes they tell us, I don't like it when mommy and daddy fight, right? Sometimes we get really clear information from little kids. And then they leave from the meeting. As soon as kids are like 8, 9, 10, they come in and participate for the majority of the meeting. And we have a facilitator that works out with them a signal so that they can tell us if they're feeling overwhelmed, if they need a break, if they want to talk to the facilitator. So that age of child, some kids choose to put their hoodie up or raise their hand or pass a note to the facilitator. And then the facilitator and the social worker walk outside with the child. This is pre-pandemic. I'm giving you the scene, right? They would walk outside with the child and just check in with them. Sometimes kids would say, I'm bored, I don't want to be here anymore. Sometimes kids would say, I want to say something, but I don't want to say it out loud. Can you say it for me? So then they would come back in. So we just had this model built up where the child could be present, that we could make sure they were tolerating that, and that they were giving their input. We also require all of our tribal partners to be involved. In San Diego, we have the most Native American tribes here in San Diego, and we have great relationships with all of our tribal partners. Any professionals involved with the case, our skilled and trained facilitator. And then here are the not required, but highly encouraged. These are our natural supports and our community supports. I just want to argue for a minute that these bottom 2 are probably the most important to the family, right? So we work really hard to make sure these people are present. We know when we have the right people at the table, we get the best information. So having grandma and auntie, the neighbor, mom's best friend present really helps us get a more holistic picture of the family, as well as increases our ability to meet the family's needs ongoing and after we leave their family. So at the exact same time we rolled out CANS, which was October of 2018, we implemented our contract. So we had behavioral health and child welfare and probation came together, and we made a joint contract to hire a contracted facilitator, contracted provider. There's actually 35 facilitators. We really spent a lot of time training them about our organization and how to engage families, how to de-escalate tense situations. But what we didn't spend a lot of time was teaching them about child welfare specifically, or probation, or behavioral health, because their role is to be that neutral provider, that neutral facilitator that doesn't have a side. One of the biggest concerns the state of California had heard was that when I'm the social worker when a social worker from child welfare facilitates it, even if I'm not the assigned social worker, they're biased towards social workers, right? They're biased towards child welfare practices. If a therapist is running it for themselves, the therapist is pushing their agenda. This is the feedback families gave, right? And it makes sense, right? We understand our own organizations. We understand the benefit. So we're going to talk a lot about those. When the neutral facilitators came on board, it really increased family satisfaction with the process. They really felt like that neutral person was representing everybody's perspective and making sure everybody's voice was loud. Real quick, I just want to let you know that the state of California requires both behavioral health and child welfare services to complete a CANS. Our CANS is similar. We both have the same core 50 items, but it's not the same form. They're different forms. And behavioral health has 3 expanded modules. So if you score a 2 or a 3 for substance abuse, identity, and there's one more, then juvenile, it's like juvenile probation involvement. Those create an expanded module for behavioral health. And for child welfare, ours has 4 caregivers that we assess. So that's mom, dad, whoever's on the case plan, mom, dad, whatever that case plan looks like, and the person the child lives with. So they're a little bit different. We are also required to provide them, upload them back into different systems. So really any child that interacts with child welfare and goes to therapy is getting 2 assessments. But we work really hard to make sure that we're sharing those assessments back and forth, that we're sharing all of the information so that we can reduce the impact on the child. So we started in April 2018, had some, of course, in the beginning, social workers, it was rough. Those first 6 months, we changed both our facilitation process and added in the CANS conversations. There was a lot of resistance. But after 4 to 6 months, social workers started coming forward with lots of positive stories about what was working well in general. So then comes March of 2020. And all of a sudden, we can't have in-person meetings anymore. And we also had a disruption. So we really reduced our number of meetings. Our child and family team meetings, we averaged, on average, we have 240 meetings per month by a facilitated child and family team meeting. And we went down into the 30s for a couple months, right? We were really impacted by COVID transition. Those meetings were all just on phones, or there's this app called Conference Now app, but it's just voice. And boy, those are rough meetings when you can't see people and you can only hear them. It's very hard to tell who's talking. So we worked with behavioral health, actually came into some COVID money from the government, and they purchased 30 Zoom accounts for our contractor. And we required that the contractor use Zoom for all of the meetings. So this happened in the fall, I'm going to say like August, September of 2020. We started getting all those Zoom accounts up and running. So here's some of the outcomes. We had, as mentioned before, huge increased attention at child and family team meetings. It made it so much easier for those natural supports and relatives to come to the meeting. Sometimes they live out of county or out of state. And while we would include them by phone previously, being able to be part of the Zoom meeting really, and everybody was participating by Zoom, really made them equal partners. We found that most parents like the audio format. So they like that Conference Now app. But the kids and the teens wanted the video format. They wanted to be able to see who was talking, kind of like Liz mentioned. They wanted to make sure they knew who was saying what. And if they were disclosing, they wanted to be able to see people's reactions for the teenagers. The parents seemed to be more comfortable not seeing their reaction to their disclosures or their conversation. We found that team members speak up more. So we're getting even more engagement overall in the child and family team, and also in the CANS conversation, which is critical because that's how we determine the case plan items. Really improved ease of scheduling, including those formal and informal supports. The facilitators have more authority over upholding group agreements. So we have a group agreement that everybody has to agree to, that they're going to speak respectfully. Well, if somebody violates that and they've been reminded a couple times, the facilitator can mute them, right? So it kind of helps with enforcing group agreements. Obviously, we keep that to a minimum, as little as possible, but it can be helpful. Some worries, I mentioned this, youth and professionals typically prefer the visual formats, so we've really expanded the Zoom access, using Teams when possible, and then we allow call-in as an option. So at first we were letting everybody pick, do you want to be on the phone or do you want to be on Zoom? But now we basically say, oh, we're all going to be on camera. And that includes my social workers, by the way. Some social workers were not turning their cameras on, and that was not acceptable. So we had to send some messaging to social workers that parents need to see that they're active and engaged in part of the process too. The facilitator has to work a little harder to make sure everyone's voice is heard, because as we all know, when you're facilitating Zoom, if you have more people than you can see, it's kind of hard to tell if everybody who was talking was heard. We have to be really careful about confidentiality. We don't have people in a room. We can manage who's around. So we have to really remind people in the beginning, hey, we're going to talk about sensitive stuff that's only for this group. Make sure people can't hear you. I need you to put headphones on or be in a private room. And then in the beginning, this familiarity with technology was a big issue, but we've all gotten pretty proficient. Just a couple success stories about that transition where our social workers were tipping over. I had a social worker who knew her young adult really well. She had a 19-year-old who was in college. She had worked with her for over 18 months, saw her more than once a month, really felt strongly connected to her and like she knew her. And I went to a unit meeting and she said, so Shelley, I got a story for you. I'm like, okay. She says, yeah, I went out and saw this young woman. She goes, and I told her, I'm sorry, I have to do this assessment with you. And I was like, great, that's exactly how I want you to present it. Go ahead. Right? Like, I'm just like, wow, is this how we sell the cans? She goes, yeah. So she started going through the questions and she got to the depression question. And she said, do you ever feel depressed or sad? And she was already marking the 0 on the form. And the young lady said, yeah, I do. And she's like, you do? Tell me about that. And the young lady said that every morning when her alarm goes off, she hits the snooze button like 10 times. She absolutely has to drag herself out of bed. She feels very sad and despondent, really concerned about herself and how she's functioning in college, and thinking that other people can tell that she's a foster kid and that she doesn't, she feels like she doesn't fit in. So she described some pretty significant level of sadness and rated herself as a 2 for depression. And the social worker was very taken aback. Mind you, she's repeatedly asked her, how are things going? How are you doing? And the child has never brought this up. So then she gets to anxiety and she's like, do you ever feel anxiety? And the young lady said, yeah, I do. She goes, as soon as I step outside of my dorm room, my heart starts beating really fast. And like, sometimes the sound gets kind of fuzzy. I can't like really hear everything everyone's saying. And I go to the door and I put my hand on the door of the classroom and I just don't even want to open that door. It's hard for me to breathe. She's like, and eventually I make myself open the door. She's like, but I'm so nervous. They're going to ask me a question and I won't know the answer. And she just described this anxiety. She scored herself as a 2. And then they got down to the trauma module and the social worker was reviewing them with her. And this young lady had been in care for over 5 years. And she disclosed for the first time in that session that she had been sexually abused over 7 years ago. I'm going to stop sharing. And that's when my social workers were like, this tool, like we jokingly and lovingly say around here that there's something magical about the cans. Like, we're asking kids all the time about if they're sad, if they're anxious, what's going on with them. But there's something about this format and taking the time to have the conversation that we're getting different information, more thorough information, more accurate information. And she actually ended up taking a leave of absence from the school for a semester, so that she said that she felt like if she didn't deal with this sadness and anxiety now, that it was really going to impact her future. So the social worker was like, we would never have had this conversation. She felt like that wouldn't have come out until maybe a tipping point when something was really going poorly. So, lots of stories. My facilitators talk about how much more kids communicate during child and family team meetings because of the CANS conversation. Kids usually introduce themselves in the beginning. They don't talk too much about it. And then when it came to the CANS time of the conversation, they would be active participants. And there's been many, many examples where kids score themselves higher than we would have scored them. We don't know what's in people's minds, right? We're doing assessments, we're guessing, but unless they tell us themselves, we're just making our best assessment. So having those children present and be part of that conversation, and then using the CANS tool to create the case plan, has just been a huge shift for us. So it was a slow transition to virtual. We definitely find the Zoom is better than just having voices or conference calls. So I don't know if that's an issue for anybody with your family meetings, but it makes a big difference. And I can put my email in the chat if you guys have any specific questions. Oh yeah, thank you. Brandon just messaged me. In my slide deck, yeah, please do. We made 5 videos that show a mock child and family team meeting having the CANS conversation. So it's like, they're all like 3 minutes each, and you can take a look at those. They're on YouTube.
Excellent job. So there were some questions that floated on in.
Okay.
But I think one or two of them might have been for Liz. I want to just throw the questions out there. If you feel like they're questions that were directed at some of your content, then feel free to answer. Ashley said, I'm wondering if there have been any barriers with providers only doing telehealth visits. How has Texas moved past the children that need face-to-face therapeutic sessions? So yeah, I do believe that was probably a question for Liz. I'll give you the opportunity to answer that, but I'll also ask the second question before we do that. Actually, no, go for it. Let's do one.
I was just going to say that one of the advantages to having the behavioral health services and actually medical services be through a single managed care organization. Superior Health Plan has the managed care program for children in foster care. We call it Star Health in Texas. And if you are someone that needs either a CANS assessment or a clinician for any kind of service or medical services, they can help you find a provider, and we have them in person, and we have them also in telehealth. So we are not requiring it to be one or the other. So if it's appropriate for one way, or if there's a preference for the other way, they can opt. It's optional. We've given both options. That's why to me it is so striking that for our CANS assessments, once we had a lot of the telehealth option, face-to-face CANS assessments never caught back up. But there are still quite a few face-to-face options, so now people have a choice.
Excellent. The next question, I think, did you feel that it was more efficient to complete the CANS while in the meeting, or do people find that distracting? So yeah, this was right after the question that Liz just answered. So I'm assuming it was probably based on that content, but both of you can feel free to answer that question because it might be relevant in more than just one place.
Yeah, happy to talk about that a little bit. And I can actually share in the chat, we have a frequently asked questions that helps our social workers complete that CANS conversation in the child and family team meeting. So we do pre-assessment, right? So anytime a child is removed and becomes part of a case or even a voluntary case, the social worker is always interviewing all the parties. So they're talking to the children, the parents, those collaterals we talked about, the family members and friends, any professionals. And during those initial interviews, they're asking some of those CANS questions. Are there any issues with sleep? Are there any worries about this, right? So they're fitting them in. And then we pencil score, we pre-score the CANS, the social worker does. So ours, Liz was mentioning behavioral health does it, but our social workers actually do it. The assigned social worker. And so they pencil score the CANS, and anything that's a 0, we rule out of the conversation. So we go through that, what's working well, and what are we worried about? And as the social worker, as the whole team's talking about that, the social worker is kind of adjusting their pencil score, right? Oh, I didn't realize we were worried about this, or, oh, you know what, I think that's going to rise to an action item, but that's just internal for the social worker. Then after we finish what we're worried about, the social worker says, okay, now we're going to talk about the child adolescent needs and strengths. We've already sent some information about that in the scheduling email. So we have a letter we send to all the child and family team participants explaining what it is. And then they say, okay, and we talked about these areas we talked about, there were no worries. Psychosis, you know, oppositional, all of those. Is that still true? Yes, we mark those 0. So then they talk about everything that's above a 0 as part of the child and family team. And for most kids, that's about 10 to 15 items. So then everything that's above the 0, they spend some time talking about. And everything's public facing. So we give them a copy of the guide, we give them a copy of the form, we give, you know, like, that's one of the things I love about this tool is the transparency. You know, our families have never seen this tool. And our social workers, yes, we gave them 6 hours of training, we certified them, but there's varying levels of competence in their ability to present about it. So that's one of the great things. Wait, did I sidetrack myself from where I was going with it? So then as we talk about each item, let's talk about depression. And then they'll score it. Maybe it's a 1, maybe it's a 2. And then they determine the action item for that and the case plan.
I would just add for Texas that it's clinician's choice, you know, just like people that take notes, some do it however they want to do it.
One of our biggest worries, if I may say, was that before I started, I was like, all of us were worried that families were going to be really upset that we were rating them or scoring them, that those numbers would feel like scores. Can I tell you, we have done over 10,000 CANS assessments in child and family team meetings. We have never once had a complaint about the rating. People understand it. I equate it to this, like from what I've heard from families and social workers, they understand that like a 0 is an A, right? A 1 is like a B, and then they understand that like, okay, now a 2 is like a C-, or it makes sense to them. We've never had a complaint about it. And also we score every caregiver and we don't have caregivers complaining, which we thought caregivers were going to have a fit, right? So I just, remind everybody, when we ask the questions in a thoughtful and genuine way, people answer the questions.
So Lisa had a question. How often are you meeting with the families for CFTs?
So if we did it independently every time the state requires us, we would be seeing them every 4 to 6 weeks. And that's not reasonable. Our caseloads our social workers usually have 20 to 25 kids on their caseload. While some of those are siblings, you're still usually talking about, 10 to 15 families. That's a lot of child and family team meetings. And these meetings do last 2 to 2.5 hours each. So we meet with the families. We have a child and family team, usually prior to removal. We have one within 21 days of removal because that's how we write our case plan, right? We don't create a case plan without a child and family team CANS conversation. And then we have one before every status review hearing, which is every 6 months for us. If there's something urgent that comes up or the child's going to change placement, then we will have another meeting.
Do you find that the 2.5 hour meetings are too long for the families?
We were really worried about that. So before we added the cans, so the cans adds about 15 to 20 minutes per child. So if you have 2 kids, that's 30 to 40 minutes. If you have 3 kids, that's an hour. And some of our families have 8 kids, right? So we keep an eye on it, but families have been able to tolerate the 2.5 hours. For the most part, families prefer to get it done in 1 meeting than to break into 2 meetings. Now, if we have more than 2 kids, we do talk about breaking the meeting up, or we'll take a break in the middle. We'll give everyone like a 10-minute break, right? But yeah, we were worried about that too, but it's been okay for the most part.
So Shelley, based on the sort of bureaucratic nature of state government where I live, I was wondering, were there any obstacles or barriers when choosing an app or a platform to go with? We saw a ton of that stuff when it came to confidentiality in the state of New York, when it came to licensing. Some state agencies have licenses to work with certain platforms. And so we saw a number of different issues pop up when it came to that conversation about which applications were best for which populations.
Yeah, we had the exact same issues. So remember in the beginning when people figured out how to hack into Zoom and they were breaking into meetings and doing terrible things, right? So we didn't use Zoom at all until they improved their security, which is why I think they were relying on that Conference Now app, which was all voice, right? Teams is our format in San Diego. We use Teams. Teams is not as flexible of an app as many of the other ones. So it took us a while. It really did take probably 4 or 5 months. Zoom bombs, right? Agreed. Those were terrible, and just terrible people putting terrible things. So yes, we did. It took us a while. It took us about 5 months to get on the Zoom, feel confident that Zoom had created those safeguards for the confidentiality. So it did slow us down, but we have consistently used Zoom since then, and we haven't had an incident. I'm gonna knock on wood right now, a little superstitious, but
good luck.
Excellent conversation. Others, if you have any questions, please feel free to chime in and ask your questions of all 3 of our presenters for this afternoon.
So I have a question. I will have a shout out, first of all, Shelley, to you. San Diego County's implementation never ceases to amaze me because so there's still a number of places that are, kind of plugging away and trying to get there. And you guys, in the space of really a few months, you've gotten to a depth of implementation that lots of places still dream about. And so I'm wondering, I think you said a few things that are probably parts of the secret sauce, but I'm wondering if you might just pull it all together and kind of what do you think the key components of why it became so straightforward for you? I'm sure it wasn't easy, but why you were so successful in such a relatively short period of time getting meaningful use of this approach.
Yeah, after the first year, I started coaching a bunch of counties, but you're right, a bunch of counties still aren't even using it the way that the state intended, right? So when I meet with those counties, I have a coaching PowerPoint that I do because I personally, the tool is amazing. It does what it's intended to do, but we need people to believe in the tool and use it, right? So to me, it's so much of it's the communication, the messaging that we give, the way that we implement the training, the way that we follow up and provide support. I believe that me physically walking into the office every week for weeks after we started the rollout so people could yell at me, right? People were like, "Oh, Shelley, your tool sucks." And I was like, tell me why. First of all, it's not my tool, but why does it suck? By the way, when people love the tool, and they're like, "Shelley, your tool is awesome." I never say it's not my tool, but and I really believe that me going to all those unit meetings and letting people yell at me was the best thing I could have done, because then I could dispel I could help them figure out the way to use it, and I could help them figure out the thinking, and I could reframe it for them. A big mistake I made in the beginning, I'm gonna say for the first 6 months for sure, was I kept telling the social workers, You don't know what the case plan is. You don't know what the case plan is until we do the cans. Well, I mean, the truth is the social workers do know, right? We didn't change our services. We didn't change the way we do business. We changed the way we did the assessment and how we helped families be part of that and make their voice really loud and help them understand. So when I switched from saying that, here's what I started saying. I know you're the expert about case plans, and you could probably guess what's going to be on the case plan when you read the narrative. But here's the thing, your parents have never been part of this system. And we need to slow down and help them understand. If we can help them see, oh, okay, this is a 2 for substance abuse, or maybe a 3. That's why the level of service differs, right? We can help even show that with the 2s and the 3s. This needs intensive services. This is really derailed your life. The buy-in and the engagement from the families is worth every extra minute we spend, right? Even if it's a couple hours, it's so worth it, because then they understand and they become engaged. And we literally see kids. So after I was going every week, so after a couple months, social workers were like, oh, Shelley, your tool is working. And then of course I was like, thank you. But what they were telling me was that they were like, oh my gosh, like they get it. So they're getting into services. I started unsupervised visits at month 3 or month 4. Usually this didn't happen until like month 7 or 8. And so just having parents understand and connect and it makes sense to them, it's what a positive impact for the whole family. Every day that kids are, you know, this, I don't know how to say this without the negative. Every day kids are not out of home. Every day that the sooner kids can return home, sorry. Every day earlier we bring them home, we improve that transition home, because it's hard to transition from out of home care to in-home care. But the longer that gap is, the harder it is.
So I'm going to interpret something that you said for the rest of us, because I don't think you'll ever say it. And I think it's also true of Liz, of you in Texas. I think leadership matters, and leadership matters enormously in these kinds of implementations. I think one of the reasons why both Texas and San Diego County have been successful is the leadership believes in the approach and supports it and kind of sticks with it through the inevitable complaints. I think credit to both of you for putting up with what happens, so I mean, I think the other thing you might have done is amplify successes in a way, and maybe that's just a culture of your office that's less complaint focused and more compliment focused, because you gave a couple examples that I think are testament. That happened in Tennessee too. Their implementation took off pretty fast because they quickly had some successes and they took it upon themselves to amplify those successes. So people heard about the successes rather than oh, this takes forever to do, or I hate doing that, all that kind of stuff that you hear. So anyway, kudos to both of you. So I think it's absolutely fascinating.
I almost brought my award from last year over because nobody cares besides this conference.
We care, so we value that award. So. It's funny because culturally we shame people who commit. We shame them. My parents' generation called them apple polishers. My generation called them brown nosers. My kids' generation called them ass kissers, right? So we've always, in Canada, we call them keeners, right? So we always have a way of shaming people who care and shaming people who get engaged in doing something, which is so tragic. I mean, it's just so tragic that we culturally choose to do that because we actually diminish ourselves collectively in that process.
The thoughts or ideas, concerns or challenges even.
Yep.